Sir,
Yes, yes, yes.
good morning everyone. I, Dr. Romesh Bagde, on behalf of PG Education Committee of Psychiatric Society of West Zone, welcomes you all to the ninth edition of 4 series of our own scholarly Sunday session. Today we have long case presentation and discussion. So hope we have a great learning experience by the end of this session. So before we start, I would like to welcome Dr. Sudhir Bhave sir, President Psychiatric Society of West Zone. Please, sir, say a few words.
Thank you so much, Sushil. I'm sorry. Ramesh.
Ramesh?
Yes.
I'm very happy to be here in this program today. I think as I've been seeing the program for the past, 10 months, Sushil has and his subcommittee, they have perhaps covered anything that's important for PG. I mean, right from planning the thesis, the entire thesis, the different parts of the examination, the way one needs to appear for the theory, Viva, OC, and so on. So I think any PG who has attended all the programs and would be seeing some of them on the YouTube will be greatly benefited. So Sushil, congratulations for all the choices throughout the year, roping in the correct faculty, getting the PGs to present just the right things. And I know that you got tired of my praising you every single month. Okay, but then I think this being the grand finale, I cannot but admire you specifically for all those creative ideas that you have been having throughout the year and hosting such wonderful programs. And I must say that today Paraksha and Hira Merchant are going to be the showstoppers, this being the last program. So this is the Rag Bhairavi of this subcommittee. So Sushil, thanks a lot for doing so much for the West Zone for the entire year. Over to you, Ramesh.
Thank you so much, sir, for your kind words. Now, I would like to welcome Dr. Sushil Gawande, sir, Chairperson, PG Committee, PG Education Committee. Sir, say a few words.
Okay. Am I audible?
Yes, yes.
So thank you, Ramesh. Thank you so much. And thank you, Bhavesh sir, for all the praise. I am receiving it every month in third week, and that motivates me to do more for the next month. And specifically, I have planned something which would be useful for PG students. And now the third year students are appearing for their examination. They have their prelims on 27th onwards in different colleges around 1 or 2 days before or after that. So I had thought of keeping long case at the end, and I was behind Dr. Paraksha since so many days. Means he could not adjust his dates for the previous last two sessions, and then I was with him that for this session I want you, and that is the reason we have postponed the time of this session from 10 to 11 to 11 to 12. So thank you, Parag sir, and I equally thank Hina. Hina means we were talking on one other topic, and then suddenly I told Hina, yes, please come as a teacher for this session, and she so warmly accepted the invitation. So thank you so much, both of you. And as this being the last session of this Scholarly Sunday and this PG Education Subcommittee, I would like to thank my advisor, Shilpa ma'am, and convener Sri Lakshmi, and all the wonderful members like Romesh, Venona, then so many people, all the committee members. So whenever I have allotted them some task, it was never no from their side. They accepted the task so happily and they tried to make it so beautiful. So I thank all my committee members for putting all the efforts to make the program so successful. So it's not a success of one chairperson, it's a success of entire team. So thank you again, my all team members, West Zone President, Secretary, and Advisor for giving this opportunity. And without a further ado, I hand over the platform to Ramesh. Over to you, Ramesh. Thanks.
Thank you so much, sir, for your kind words. Now
Thank
I
you,
would like to
Sushil.
welcome.
Yes, ma'am.
Now I would like to welcome our two esteemed faculty for today's session, Dr. Parag Shah sir and Dr. Hina Merchant ma'am. Dr. Parash Shah is a professor and head of department in Surat Medical College. He is PG teacher and examiner in various platforms. He is DNB exam assessor. He is direct EC member of IPS. He is EC coordinator in IPS and various multiple subcommittees. He is in National Advisory Board and he is associate editor of Psychiatric Journal of IPS. He is chairperson, advisor, and on panel of various government departments, NGOs across India and Gujarat.
Thank you, Dr. Romesh. And at the outset, let me congratulate the PG Psychiatric Education Subcommittee headed by Dr. Sushil Gavande. I'm so very happy to be a part of this program today. Although I know I would always have loved to be participating initially in the middle of the year, but at least I'm happy that I can be a part of this last program for this year. I congratulate wonderful conduction of this series. And I know my students know, and every psychiatry department, PG departments, PG students know very well how wonderfully we have been having these programs this year. And I'm sure now the momentum has reached to a level that, as Bhavesh sir was rightly saying, we cannot just stop. Uh, Even if we are tired, our PG students are wanting it more and more and more. And they are all very happy and very participative in this very successful series of programs. Congratulations to the whole committee and the hard work you have been doing for last 2 years. Thank you so much for inviting me. It's my pleasure. I'm looking forward for a very interactive session in the next 1 hour. Thank you.
Thanks.
Thank you so much, sir. Now I would like to welcome Dr. Hina Merchant ma'am. She is additional professor at Sion Hospital. She is immediate past president of Bombay Psychiatric Society. She is EC direct member of IPS. She is treasurer of Staff and Research Society at Sion Hospital. She is current editor at Annals of Psychiatry. She has edited many books. She is EC member of IPS WZB and she has received Bhagwat Award in the year 2004.
Thank you, Romesh. Thank you for this kind introduction. I'd like to take this opportunity. I actually did not think this was the last one. So thank you, Sushil. Thank you, Bhave sir. Thank you, Shilpa ma'am. Thank you for having me. It is indeed my pleasure. Of the books that Romesh mentioned, there is one book that we have written, which is the postgraduate case presentation book. So I would also use this platform to sort of request all the PGs to kindly buy this book and also go through it. I think we've tried to make life pretty simpler. It's almost most of the information is kind of spoon fed. So I would also urge the PGs to kindly refer to that book. And without further ado, I think we should start with today's program.
So with due permission of all of you, I would like to introduce our presenter for today's session, Dr. Ritu Raj Jadhav, third year resident at IGGMC Nagpur. So without further delay, I would like to hand over the virtual floor to Dr. Ritu Raj.
Thank you so much, sir. Is the presentation visible?
Yes.
Hello, am I audible?
Yes, yes.
Um, Thank you to all the authorities and the faculty members for allowing me this opportunity. So my patient is Miss ABC, a 30-year-old divorced Hindu female, resident of Agdara, Ingna, Nagpur, having studied till 7th standard, currently unemployed. She was brought by her mother, Mrs. FGH, 55 years old, and neighbor, Mr. IJK, 40 years old, adequate and reliable informants, to Regional Mental Hospital, Nagpur, with chief complaints of muttering to self, reduced interaction, suspiciousness, hearing voices, and disturbed sleep since the last 3 years, poor self care since the last 1 year, and pelting stones, assaulting, gathering, and setting fire to garbage and clothes since the last 1 to 2 months. My patient was apparently all right 3 years back when she was brought back to her maiden home by her husband and given a divorce. After approximately 1 year of marriage, he stated to the patient's family that she did not perform any household chores, and he stated that she was mad, and thus he left her at her maiden place and then did not return. When at home, the patient's mother, who is our informant, she observed that the patient had started interacting less and less with the family members, with the outsiders. She had started staying alone, and while staying alone, she had started mumbling to herself. Most of the time, the what she was saying or who she was talking to, that the family members could not understand. And whenever they could understand, they could only make out a few words in between and could never grab the entire context of what she was speaking. When asked that what are you talking about, what are you saying, initially she was very much dismissive and denied having any such behavior. But over a period of time, she started becoming angry and started saying that why are you repeatedly asking me all this? I have already told you that I am not doing any such behavior. In over the next 1 to 2 years, the mother started noticing and observing that this behavior, its nature was such that she was talking to someone else. It seemed like she was talking to someone else, and huh. And while talking, she had started developing some sort of gestures also. Along with this complaint, since 3 years, she had started sleeping less and less. Her previous sleeping time was 11 p.m. to 12 a.m., and she used to wake up at 7 to 8 a.m. And now she had started sleeping less and less. Only for a few hours she used to sleep. Rest of the time she used to stay awake in the house. She again used to talk to herself. She used to wake up her family members. She used to get angry even during the night. And when asked why are you not sleeping, then she just used to say that I am not getting any sleep. And so what is the problem if I am not getting any sleep? Always she used to always get into an argumentative stance regarding this. 1 year after the complaints started, that is now approximately 2 years back, her mother noticed that that the patient would repeatedly say things like, "Why are those outsiders staring at me? Why are they staring at our house? Why have they stopped in front of our house? Uh, are they looking at me in a wrong way? Are they going to do something to me?" In this manner, she had started becoming suspicious, and what they will do to her, why they are staring at her, that this she had started asking. Over the next 6 months, over the next 1 year, these statements started becoming non-specific, not only towards outsiders and passers-by, but also towards her distant relatives, towards her family members. First, towards the relatives, whenever any relatives used to come to her house, she used to get irritable. Oftentimes, she used to deny them entry. She used to say, "Why have you come here? You have come here to cause loss. You have come here to take me away. You have come here to harm me." Other times, she used to retreat into one corner of the house, and rest of the time, she did not used to talk to any relatives. And if anyone approached her during that time, she used to become irritable. She had started hurling abuses even, and and then this behavior later on extended towards the family members as well, such that she started repeatedly accusing family members that you guys are always talking about me, you guys are looking at me in a wrong way, you will do something to me, you will get some I don't know what benefit you will get, but you are after my life. She had started checking food that was made by the family members served to her. And sometimes what she used to do was she used to divide the food into two parts and eat only half. Sometimes she used to completely throw away the food. She started taking more and more time to complete her meal because she used to check every morsel, every small bit of food, and thus she had started eating less also. In the last 1 year, she started saying that she could hear the family members talking about her behind her back. She could hear the villagers talking about her, calling her name, uh, calling her name, giving her bad words, abuses, saying that they will kill her, they will slash her throat, they will take her away. Many times it started seeming like she repeatedly looked out of the window even though no one was there. She used to go outside her house door and shout and ask who is there. She used to, it seemed like she was searching for someone, but she could not see. But she was always convinced that all my family members or all my villagers, they are talking against me, they are talking bad things about me. But in addition to this, she had also this complaint that some unknown person is also talking, calling my name, giving abuses. But who that person is, I don't know. That this was also stated by her mother. And in the last 1 year, she had started taking care of her less and less, which was observed because her mother used to insist that go and take bath. And initially, upon very much insistence, she used to listen. But what used to happen was she used to go in the bathroom, she used to leave the tap open, and 2 3 hours she used to stay in the bathroom, but still not a proper bath she had taken. She did not wear her clothes properly. For example, her blouse buttons or her sari was not in an appropriate attire or was not dressed up properly for her. And she so many times she did not bath for days on end, so her hair had grown dirty. She later on did not brush regularly also, so a bad smell had started coming from her mouth. And when insisted or shouted or actually forced, at that time she only used to chew on the brush and then spit. That is all that she used to do. And even one thing that her mother noted, that since the last 3 4 months, her clothes used to become stained by menstrual blood during her cycle period. And previously, where she used to take care of these things by herself, this had also stopped now. Yes, along with this, now in the last 1 to 2 months, this was their main reason for consultation. That in the last 1 to 2 months, she had started hurling abuses more. She had started pelting stones. She had started roaming within the village and gathering garbage, collecting all the garbage. Sometimes she used to set the garbage on fire. Once or twice, she had set all her clothes at her home on fire. She had started disrobing herself in her own home, not in the village as of yet, but in her own home, she had started disrobing herself. And all this behavior had overall become unmanageable for her mother, which is why first actually around 10 15 days back they took her to a faith healer where she had stayed for 1 week. And at that time the faith healer had said that had told them that there was no improvement, and thus they had come to regional mental hospital for further consultation. On further inquiry, her mother disclosed that 4 years ago, that is 1 year before her marriage, her father died during she claimed he died during the lockdown. He had got contracted COVID disease. And after her father had died, she seemed sad. She cried to herself occasionally, and she was less talkative and did not eat or sleep properly for 1 to 2 months. Later on, these all these complaints stopped, and during this time, none of the other present complaints were there. After 1 to 2 months, these complaints also stopped. But what had happened was before this, she was also helping her parents earn money in the farmer laborer work. But after this, although these crime spells or although these loneliness or talkative nature had somewhat improved, and her sleep and eating habits were almost back to previous nature, she did not again start working, and her interaction was less only from the period time her father had passed away. Other than that, there was no history of long vacant staring spells, unresponsiveness, or maintaining bizarre postures. There was no history of fall and trauma to head, no history of loss of consciousness, confusion, any seizure like episodes or abnormal involuntary movements, no history of high grade fever or any rash, no history of big boastful talks, over religiosity, overspending, no history of major medical or surgical illness, and no history of any substance use. Coming to family history, there was no family history of psychiatric illness. She stays in a nuclear family with her mother, who is a 55-year-old farmer laborer earning approximately 4,000 per month and currently the only breadwinner in her house. And her father died of COVID illness. She is the only child of her parents, and she had a husband whom she divorced 3 years back, and she has no children from that marriage. And currently, there is inadequate social support from the family regarding her illness. Coming to the personal history, she was a full-term normal delivery born at a nearby hospital. She cried immediately after birth and claims she had attained developmental milestones and appropriate age. She had studied only till 7th standard at the Jilla Parishad school and did not continue due to financial constraints. Her parents were not that insistent on education, and she was there onwards taken into work and then earned money with her parents. Her pre-morbid personality was introverted. Since childhood, she did not have a lot of, she did not have many friends. She only used to open up to her mother about things that bothered her. In leisure time, she used to help mother with household chores like cooking, cleaning, and she used to go to work also since her 12, since she was almost 13, 14 years of age. And she used to roam around in her village in her leisure time. There was one thing that she used to get upset easily over small issues, even before her illness. Coming to examination, sorry, I would like to mention that based on the history, I have kept a provisional diagnosis of schizophrenia, and we will see the final diagnosis after examination. In general examination, her pulse was 85 beats per minute. Her blood pressure was 120 by 80 millimeters of mercury. There was no pallor, icterus, cyanosis, clubbing, or swollen lymph nodes. And on systemic examination in CVS S1, S2 were heard. No murmur could be heard. Her respiratory system air entry was bilaterally heard and equal. Her abdomen was soft and non-tender. CNS sensory and motor examinations were within normal limits and higher functions were intact. Coming to our mental status examination, patient walked into the clinic room on her own after insistence by family members outside the clinic door and then seated on the edge of the chair. She was conscious, cooperative, and communicative. She was oriented to time, place, and person. She was very poorly kept. Her clothes were disheveled. Her blouse buttons were upside down, or were misarranged and somewhat, and A1-2 were open. She had dirt over her nails, over her dorsal aspect of forearm. She had untrimmed nails. She had oily, matted hair, and there was bad smell coming from mouth and odor coming from the body. She was of a lean build. Her eye-to-eye contact with her was initiated and maintained. Rapport was established. Her psychomotor activity was raised. She had a dismissive attitude. Her attention was aroused but ill-sustained. Muttering to self and self-gesticulating was present. Mood was conveyed as chid-chid, thus it was irritable. Her affect also was irritable, reactive. It was mood congruent and not appropriate to the surrounding. Coming to the speech, her rate, tone, and volume was increased. It was spontaneous. It was irrelevant, occasionally incoherent speech present. Muttering to self was present. In thought form, loosening of association was present. One speech example is when asked, तुला इथे कशाला आणलं? She said, माहित नाही, घरची कामं बाकी आहे, झाड पडला, रात्री येईल, followed by some unintelligible speech, and then silence until we probe and ask the next question. In thought content, delusion of reference and persecution were present. बाहेरचे माझ्याकडे बघत असतात, माझ्याबद्दल बोलत असतात, मला घेऊन जातील, मारून टाकतील. घरचे माझ्या जेवणमध्ये विष टाकत मला वेडा म्हणत माझं बरं वाईट करतील. Coming to perceptual abnormalities, second and third person auditory hallucinations were reported. She said that outsiders talk about me, and even my family members talk bad things about me. They give me abusive words. Her concepts were impaired and concretized. I could only test when she was irritable about the rest. Her memory was more or less intact. Her intelligence did seem adequate. She could name the days of the week. And she could tell about the famous politicians somewhat. and her judgment was impaired, her personal judgment was impaired, her social judgment was impaired, and even her test judgment actually in the usual situations that were put forth to her, that if she finds a phone or a letter on the road, what she will do, or when if the ward is on fire, what she will do. These things she answered properly, but whenever this test situation involved her family members, at that time it was definitely impaired, that if your family members needs help or if you want to save their life, will you do it? Then she used to say that they as it is want to kill me, so why should I save their life? Her insight was poor, it was 1 out of 6. So coming to the case summary, this is a case of a 30-year-old female with complaints since the last 3 years, having a continuous and deteriorating illness, having suspiciousness towards family members and outsiders, hearing voices of family members, outsiders, and unknown people, poor self-care since the last 1 year, and abusive, aggressive, and disorganized behavior since the last 1 to 2 months. Findings on examination being she was poorly kept, having increased psychomotor activity, ill-sustained attention, irritable affect, irrelevant and sometimes incoherent speech, loosening of association, delusions of reference and persecution, and second and third person auditory hallucinations with impaired judgment and poor insight. Coming to the diagnostic formulation, based on complaints of delusions, hallucinations, disorganized behavior, and speech, which are continuous and for more than 1 year, I would like to give my diagnosis as per DSM-5 as schizophrenia continuous, as per ICD-11 as schizophrenia continuous and currently symptomatic. Some factors, predisposing factors towards her illness, a psychological predisposing factor being introverted behavior, and social predisposing factor may be being father's death. Divorce can be a social precipitating factor. Poor social support, poor socio-economic status can be predisposing as well as perpetuating social factor, and poor coping skills, as evidenced by getting upset and irritable over small issues even before illness, can be a psychological perpetuating factor. Coming to the management, first I would like to ascertain that I want to manage this patient on an IPD basis, because currently she is not in a state to take care of herself. She is currently a threat to self as well as to others, and even she is not eating enough to sustain her nutrition. So this is why I would like to manage this patient on an IPD basis. First thing I would like to do is perform certain investigations, complete a differential blood count, liver and renal function tests, her random and fasting blood sugar, her serum electrolytes, lipid profile, chest X-ray, and ECG. I would like to apply a baseline PAN-SS score for this patient as well. Coming to treatment, in pharmacological treatment, I would first like to keep this patient on SOS parenteral antipsychotics, likely injection haloperidol 5 mg plus injection promethazine 525 or 50 mg deep IM as required. If the patient is getting aggressive, I would like to start her on a typical oral antipsychotic, olanzapine 10 mg in divided doses, and I would like to start her on oral benzodiazepine also due to reported sleep disturbance, tablet clonazepam 0.25 mg at night. Currently in my MEC, she was not overly hostile or overly aggressive. So right now, I would not advise any sort of physical or chemical restraining. Coming to non-pharmacological management, in the acute phase, first I will like to explain or educate the relatives regarding nature of illness, etiology, clinical features, and importance of treatment, and whatever their expressed emotions and their knowledge about the illnesses, understand that and deal with the expressed emotions. I would like to perform serial MSE to evaluate response to treatment and titrate the doses accordingly. In the short term, once the patient is stable, I would like to discharge her on oral olanzapine at the therapeutic dose which we will have achieved after titration. And while discharging or even while in the IPD care, I would like to emphasize the patient as well as relatives on adherence to treatment and to regular follow-up. In the long-term treatment, I would like to ensure regular adherence, I would like to ensure social support by involving the family members in the treatment schedules, in the treatment regimens, uh, trying to address their concerns. I will advise social skills training, graded vocational exposure. Like previously, she used to work as a farmer laborer. So currently, under her mother's supervision, maybe she can start that work, or at least first she can start doing her household chores again, small household chores like cleaning under her mother's supervision. Thank you.
That was excellent and comprehensive presentation, Rituraj. Now, sir and ma'am, we can start with questions and discussion.
Yeah, Hina ma'am, please.
Oh, thank you, Parag. Firstly, Rituraj, I think you presented very well. There were a couple of points that I wanted to sort of, get your attention to. Usually, when we start with our socio-demographic history and when we've given our chief complaints, most of the times I have seen that there is a practice in which you mention that the disease has what has been the onset type of the disease. So in your case, it looks like it has been, an insidious onset. How has it been the course and what has been the progression? So it looks like that the progression also has been deteriorating. So that is one line that, or if at all, if there have been any hospital admissions, even that is mentioned just after you have mentioned all about the chief complaints. Your history of presenting illness was very nice and it was very detailed. I just noted a couple of points on your mental status examination. First and foremost, what I wanted to tell you is, why did you, no, in your history only, sorry, in your family history, when we talk about family history, it's usually family history of only mental illness. The other details that you mentioned, that father was 58-year-old farmer, he died, and etc., that comes under the personal heading in the subheading of social history, which I found was lacking in your history completely. Another very important thing that you missed is she's a female. You have completely forgotten to mention her LMP. There was no mention even about any, psychosexual history. Yes, you did tell us in detail. So in the social history, the details of the divorce should have come in. What you wrote in your long case, you started your long case with that there was a divorce that happened, 1 year ago or whatever. The husband came and dropped her to her maternal home and stated that she does not take self care and that she is mad. I mean, instead of that, you could have just had one line that the patient was apparently all right till whatever 3 years ago, or 1 year back, when following her divorce. This is what, the relatives noticed a gradual change in the behavior in the form of. All that was okay, but what I felt was lacking in your history is a proper description of social history. And again, in females, this is extremely vital. You did not mention anything about a menstrual cycle or LMP. So I think that is something you need to take note. Another thing also, your pre-morbid, I wasn't really very happy. I mean, pre-morbid needs to be a little bit more in detail. You only spoke about, she being introverted, having very few friends, and, and the fact that she gets irritable, when things don't go her way. But there are many other personality traits that also need to be brought out, like how she is in terms of work, how she responds to stressors, what are her particular hobbies, those things. So those things also need to come in your pre-morbid. Your mental status, your physical examination, all was good. See, mostly in long case, what I have seen is that usually people don't go into so much details. If it is normal, people just say it is normal. Always start your physical examination with central nervous system examination and then proceed to per abdomen respiratory CVS in no particular order, but always start with CNS. In your mental status examination, once you've stated, how the whether once the patient is conscious, cooperative, communicative, etc., you need to start by describing the attitude, appearance, and behavior. So under these three headings, so how is it that, my the patient was lean in constitute, how does that come later? All of this should have come right at the beginning. How she was, what was her attitude towards you in general, how she was, whether she was cooperative, whether she was hostile, so a little bit more description. Your description about her behavior, her appearance and all was very good, that she was unkept, and you even went on to give the details. That is good. Now coming to your thought, you have only mentioned your form of thought. You have covered your content of thought, but and stream of thought also, yes. But what about position of thought? Maybe the patient does not have obsessions or delusions, but that still needs to come. You also need to inquire about any depressive cognitions in the form of ideas of helplessness, hopelessness, worthlessness, suicidal ideation. And also concepts are a part of thought. They don't come after your perception. So concepts need to come. And just like how you described your delusions, you should have also described the concepts, both simple and abstract, that what was the example that you gave and what was the answer. And hence that abstract concept is, concretized or is impaired, whichever word you use. So I think all this was okay. So I think these are my suggestions, at least for your history and your mental state examination. Your summary was good. Your psychodiagnostic formulation was indeed very nice. You have actually covered all the 4 P's, which was rather good. In your case presentation, I think, I mean, because I have seen usually the examine, you're supposed to say that I will get the investigations side by side along the fact that you will also start medications. It's not like, the patient gets admitted with us today. It is only the next day that we start the investigations. We don't really, sit and say that. So I think you need to say that I will start the patient on so and so. And then side by side, I would also like to investigate the patient. And if the examiner asks you that why you have chosen a particular investigation, you need to give valid reasons, that why am I doing which test and for what. I think your choice of antipsychotic is absolutely fine. Olanzapine is good. I'm not too sure why did you choose clonazepam. You said the reason for choosing clonazepam is that it's a benzodiazepine and it will give sleep. I mean, olanzapine is known to cause sleep. So I don't know, maybe you could probably tell me a little bit more on that. But I pretty much like the rest part of your management, which was very clear, where you've emphasized the role of psychoeducation, which is very important here, because there was a gap in the treatment that was initiated, because they did take her to faith healers. So there has been some amount of gap before she came to your OPD. So I thought all of that was very good. I think overall, a very good presentation. These would just be my some inputs to, sort of just get your history, mental state, and when you present your long case in terms of management, to have it in order.
Thank you so much.
Okay. Yeah, so from my side, Ruturaj, a couple of inquiries. Is the patient staying alone, if I just missed that fact?
Sir, no, the patient is staying in a nuclear family with her mother. She was staying with her mother and father, and her father passed away 4 years back.
Yeah, okay. So the mother is the lone caretaker right now for her.
Yes, 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 sir.
Okay. And did you mention about the negative history?
Yes, sir. I had mentioned about negative history regarding catatonic symptoms. I had mentioned negative history regarding manic features, regarding any organic cause of illness, and regarding any OC features or depressive features.
Okay. I'll be interested in knowing from you that why did you specifically inquired and mentioned about this negative history in this case? Why I
Okay.
want to know is because when we want to be very clear about a diagnosis, I think negative history is as important as positive one, because you
Yes.
want to be sure what it is and you equally want to be sure what it is not, to
Yes.
differentiate and exclude and include and be very precise in your diagnosis.
Yes.
So how did you decide to note down the specific negative histories? What made you think about those things?
Okay, sir. So mainly the patient had presented to us with a history of 3 years with psychotic and disorganized complaints. So the preliminary differentials that we will consider are schizophrenia and schizophrenia spectrum disorder, schizophrenia for brief psychotic disorder, and schizophrenia even schizoaffective disorder. We can consider mood disorder with psychotic symptoms as one of the preliminary differential disorders. We can consider OC with either absent insight or with psychotic features. And we have to consider organic causes of psychotic symptoms like any autoimmune illness or any fever, any head trauma, which is or any metabolic abnormality, which is resulting in brain damage. So these things I had considered, and all of this I wanted to rule out, and which is why I had asked this specific negative history survey.
Okay. Suppose any given case or a typical patient has a very clear, crisp history, very definitive diagnostic positive history, leading to a single diagnosis. Do we still need to ask and rule out anything in negative history in any given case? Do you think it is still important?
Yes, sir, because many of the times what happens is that even if the positive history is clear cut, the patient informants will only mention things which have bothered them, and they will many of the times mask or not mask, but they may forget to mention other things which are important and which may change the diagnosis. So it is important
True,
to ask, I feel.
true. Yes, yes, that's true. Does the patient has any treatment history apart from faith healer consultation?
No, sir. This is the first allopathic consultation to a psychiatrist that a patient has done. Only they have gone to a faith healer approximately 50 months, 15 days back.
Okay. The onset of the illness was before round about 3 years or
Yes, sir.
4 years.
So 3 or 4 years. Still, the thing is, after our father's death, it may have been a depressive episode, or it may have been the start of a prodrome, uh, which can occur in a genetically susceptible individual. So that is yet
So
not.
my question is, if the onset is before 3 years after the divorce as the precipitating event as considered by you in diagnostic formulation, how would you consider the death of a father after which she was found to be depressed for 2 months? How do you understand that phenomena independently? And the other scenario is total duration of 4 years, the precipitating event being death of the father. Prodromal phase could have been a depressive period of 1 or 2 months, after which gradually the psychotic symptoms set in. Which out of these two things you think is most probable?
Sir, what I think is that recent literature has introduced a term which is high risk for clinical psychosis, which is somewhat similar to prodrome, but high risk for clinical psychosis is that people who are genetically, that is biologically, as well as psychologically and socially susceptible. So after her father's death, she came into this category of clinically high risk for psychosis, while not technically being a psychotic patient. So that is how I would categorize her father's death and its role in her illness.
So based on your this response, I have a query that in this patient, what makes you believe that she is at a high risk for clinical psychosis? What pointers in her clinical picture make you believe that?
Uh, Sir, she had a low socioeconomic status. That was one risk factor. Uh, Definitely the social risk factor of divorce and father's death. Those were risk factors. Then her in her pre-morbid personality, she was introverted, and she was taking stress easily, which it points to poor coping skills or poor response to criticism. That is another risk factor.
Because I found not a very clear-cut high risk kind of background in this patient for psychosis to develop, not a strong biological background or any other strong pointers in past history. Somebody giving a past pre-morbid personality information, commonly you must have asked the mother about how she was before the onset of the illness. And the relatives or the mother reporting that she is a bit sensitive or she gets affected too frequently. Every such statement or impressions of the informants has to be judged and evaluated with your own clinical discretion, because everybody has their own concepts of describing the patient's pre-morbid personality also. So maybe all those things may not be very definitive or very clearly contributing to the current illness or its background. Okay. What is the typical age of onset for schizophrenia in general, majority of the patients?
Sir, in males it typically starts in their mid to late 20s, and in females it starts in their 30s, sir. And if it is starting after 65, it is a very late onset, and if it is starting after 45, it is late onset schizophrenia, sir.
Okay. One more point that I would concur with Dr. Hina is that your chief complaints and history of present illness was very good, elaborate, uh, encompassing every aspects of her presentation in front of you. But you would have given a little bit more emphasis also on ODP, origin, duration, and progression, which is equally important, which was somehow, I thought, curtailed to a limited information. Okay, she also asked you about the last menstrual period in this patient and the history about it being important. Uh, why do you think it is very important in this patient to know her menstrual history? Any other reason that you can think about?
Sir, one of the most important thing is that in such a disorganized patient or those who are having prominent thought disorders, she may have been taken advantage of and not opening up to it, which in the last 1 to 2 months leading to worsening of her symptoms as we have seen. So that is an important thing, whether to detect she is pregnant or not, or which may be a
Anything
pointer
else?
towards.
Yeah. Anything else with regards to future
Another
management?
thing is if there is a whenever we are starting any antipsychotics, they are prone to cause irregular menstrual cycles, and this we need to differentiate whether it was there from before or whether it is an effect of our treatment.
Yeah. Now, if I ask you, how do you know the complete picture, you know the patient now very clearly. How do you see the prognosis of this patient? And what would be the good and the bad prognostic factors that you can count on?
Sir, coming to the good prognostic factors, there is no family history. The duration of untreated psychosis is not too long, and yes, there is a precipitating, there are definitely external stressors present, which count in a good prognosis for schizophrenia. In bad prognostic factors, disorganized behavior is there. There is no history of previous treatment uh, for her illness. So those are currently the bad prognostic factors. And since it is a first episode psychosis, the response to treatment will actually garner the course and prognosis most importantly.
Yeah. So again, the same question of how do you see the prognosis? I'm asking in a different way. What is the anticipated course of this illness with your olanzapine started, haloperidol injections during IPD, and then patient maintain on oral olanzapine by you from now onwards? What do you think would be the response of treatment, and what is the anticipated course of the illness in this patient? What do you think, your judgment? If the relative asks you, sir, ये बीमारी आगे कैसी चलेगी, कितनी चलेगी, कब ठीक होगा, दवाई कब तक चलेगी, on what judgment you would answer them?
So, sir, on olanzapine, I would expect a good response to our current psychotic and disorganized behaviors, and I expect them to at least improve significantly, if not resolve completely. As it is a first episode, I would like to keep her on treatment for at least the next 1.5 to 2 years, and then consider tapering off and then stopping treatment if there is no recurrence of symptoms. If there is recurrence of symptoms, I would like to keep the treatment ongoing indefinitely till now, as there is always a higher risk of relapse even after tapering off and stopping the treatment. Coming to the course, I would advise the relatives that any stress factor or any stressful events or stressful life events can precipitate the symptoms, and advise them regarding regular follow, which will keep her in a functional range. and I will tell them that it has good prognosis for now, and she can live a functional life.
Okay. If the relatives ask you that, sir, what can we do to ensure the best prognosis so that we have maximum positive outcome of this illness? For this patient, what do you think are the most important two things which would matter in ensuring the best possible prognosis? What advices for relatives in this patient?
For the relatives, sir?
Yeah.
Okay, so first and foremost, psychoeducation, that is first assessing their knowledge and telling them about the diagnosis, about the treatment, about the modalities of treatment. Advising them that not just to look at the patient's illness, but to look at the patient herself, integrating vocational support, integrating her into the household chores, asking her mother if later on when that patient becomes better, asking her to take to her with work, to work with her under supervision. So
Okay.
that psychoeducation and vocational support and social skills.
Okay, Dr. Ruturaj, this was a generic reply to, in general, any patient of schizophrenia. How would you take care? My question was very specific. For this patient, what would matter most? Okay, I'm again asking the same thing in a different way. What do you think would be the biggest challenge in management of this patient?
Sir, most important thing will be that again they might look. She's 30 years old, so they might look to her for marriage, and maybe after marriage, many times we encounter that after marriage the treatment again stops. So that is one thing we should warn the relatives against doing.
They took almost, if not 3 or 4 years, at least 2.5 years, or at least 1 year after starting of acute phase symptoms to reach to you.
Yes.
What was the reason for that delay?
Sir, two main reasons were there. One was stigma regarding psychiatrist and taking her to a psychiatrist, and second thing was that since the last 1 year she had reduced self-care and reduced interaction symptoms, and since 2 months she had become aggressive. And after failing all other modalities, they went to a faith healer. Then they decided to come. So mainly stigma and lack of awareness. These were the two things.
Okay, fine. Thank you. Thank you so much. I'm done.
Uh, uh, Ruturaj, what were the other prognostic factors, poor prognostic factors, besides the three that you mentioned? I think you forgot to mention lack of social support, which is very, very crucial. And in your good prognostic factors, the fact that she's divorced is another bad factor. One of the good prognostic factors is being female.
Yes, ma'am.
Definitely, there were no protective factors in your case. To add to what Parag said, I would like to ask you, if had the olanzapine not worked, what were you going to be? What would have been your next step?
Okay, ma'am. So before stating that, some again, when we are assessing any treatment failure, first we have to look whether the treatment has gone on for an adequate duration.
So your
Then,
patient is here with you. You have admitted her. So I think the chances of patient having missed the dose, and I think we can completely rule those things out. So my question is very straightforward here: is had your patient not responded to olanzapine, what would have been your next strategy?
ma'am, if olanzapine had not worked, I would have tried first generation antipsychotic.
So would you have stopped olanzapine? Would it have been an add-on? Or would you
No,
try to
ma'am,
add on from a second generation? What would you do?
I would have down tapered or down tapered olanzapine and started the typical antipsychotic and kept that as a primary mode of treatment.
What do the guidelines say?
Ma'am, the guidelines currently say that first we should do a monotherapy only rather than polypharmacy. And
Okay. And if
before,
that monotherapy drug does not work, what is the second best approach?
if monotherapy drugs are not working, if we have tried two different kinds of drugs, and then we can approach towards a diagnosis of treatment resistant schizophrenia, for which clozapine we can try. And if there is partial response to antipsychotics, even olanzapine or the second antipsychotic which I am trying, if there is partial response, I can try ECT to ensure a better response to the same
You
drug.
didn't consider giving ECTs in the beginning. You said one of the reasons for giving her IPD admission is, you used the word in your slide, was that she's a threat to others. So doesn't ECT then become the first and foremost indication, especially, and your patient was not even eating, and your patient had very bad disorganized behavior, very poor self-care and all? Would you have thought of ECT then?
Ma'am, actually, what literature, as in what Maudsley has said, Maudsley's textbook had said, is that ECT for chronic and acute schizophrenia may not be as useful as antipsychotics. The preliminary indications for giving ECT is to control acute agitation, which I did
And
not
what about
in
the
my
fact that your
MSc.
patient was homicidal? Wouldn't that come as an indication for ECT? Okay. Another thing is, a lot of was discussed regarding the psychoeducation. I want to ask you something about expressed emotions, which is equally important. Is what were the type of expressed emotions did you encounter? You said that the mother is the primary caretaker, right? So
Mhm.
when you were interacting with her in the ward and everything, what did you feel? What were the kind of emotions that you encountered? And what is it you're going to do? Are expressed emotions important?
Definitely, ma'am. Expressed emotions are important, and
Can
then
you enumerate the 4 types of expressed emotions?
uh, uh,
You need to know first what they are, so then gradually you can work. Okay, why are they important?
Ma'am, expressed emotions play a very important role in the social support of the patient. That if they can hamper the social support, or they can hamper patient care by the relatives who are ultimately taking the burden of the illness as well.
So in this case, did you encounter a particular style of the dealing of the mother with the patient?
Ma'am, there was no any hostility as such.
Okay,
And
that's one. What about the other? What are the other expressed emotions?
ma'am, others are I think, critical comment,
Okay, criticism, hostility,
hostility,
which is the
and
third one.
so
Over involvement.
over involvement is.
So did you ever? It doesn't look like there was any over involvement here. Which is the other fourth expressed emotion? Warmth. So was that there? I mean, what do you think? And you think that it is especially important in your case?
Yes, ma'am.
Why
Warmth
is
is
it
not
important?
there. Uh, Critical comments were there, and some amount of frustration was there regarding illness. Expressed emotions in my case are particularly important because there is only one caretaker. And
Yes, and that too, she's widowed. So it is equally important for us to also assess for her mental health.
yes.
Right? So besides the fact, when you tell her that she has to take care of the patient, see to it that medications have to be given regularly, it is also important for you to also take note of her mental health needs. So it is important that she needs to know that not only are you there for her daughter, but you are also there to support her in case it's required. Would you talk about depot in this case?
Ma'am,
Or would you consider depot?
ma'am, not at present, ma'am. First, I would like
But
to.
is it something that you would like to consider maybe in the long run?
In the long run, definitely, ma'am, because again, they have financial constraints which will prohibit them from regular
Which,
consultation.
if there are financial constraints, are there any other cheaper alternatives for long acting that you know of?
Ma'am, most common that I have used, which is affordable, is haloperidol, halodecanoate, 50,
There
100.
is also flupentixol is also available.
There is
Yes. So that is also something that can be considered. So do not completely rule out giving a long acting, because you really do not know how good or bad the follow up is, going to be.
Yes, ma'am.
So I think yes. Yeah, this is right now I can think of. But I think overall very well presented. Uh, Please go through guidelines. I would also recommend that you go through our IPS guidelines, because
Yes,
I've
ma'am.
seen many examiners also ask those. So it's good to know Maudsley, but I think it is equally important to know what our guidelines are, because these are most suitable for our population. So if the mother were to ask you that for how long should I be continuing treatment, what would be your answer?
I would tell them that for at least the next 2 years, she will be
Correct.
on
And
treatment.
along with that, when you stop the medications, you also need to give them a heads up regarding early warning signs. So in the event that, if they notice any change in her behavior, change in her mood, change in her sleeping habits and all, she needs to be brought. Because what is the course of schizophrenia?
Ma'am, it is chronic, continuous, and deteriorating most of the time.
So how many percentage of the people actually have complete remission and stay in that remitted state?
I'm 30 to 40% people achieve remission upon treatment, but not all of them stay in that remitted state. Out of that, almost I think 60% out of those who achieve remission, when taken off treatment, they will again relapse. And
I Dr. Parag had asked you this one question, that she's 30 years old, and maybe the mother could think of remarriage. So would you advise something, like most of the times, parents, they come to the OPD and they ask us की ह्याचे लग्न करून द्यायचे नाही करून द्यायचे, काय करायचं? So at that point in time, you as a psychiatrist, what would your opinion be? What would you suggest?
I would suggest two things. I would first tell them that definitely she can get married, and second thing I would suggest them is to relay the complete history and the ongoing treatment to the in-laws, and just making sure that even after marriage the treatment is still going on, because that will
So Ruturaj, I'm going to stop you here. We do not advise anybody for marriage or against marriage. What we do, what we do tell them is that it is their decision. But
yes,
when they are making that decision, we have to present to them all the facts. What are the risk factors and all? And the ultimate decision lies on them.
yes, ma'am.
Okay, so you do not tell anybody, you don't tell them that, हाँ, शादी करा सकते हैं. Okay, so you need to be careful that. Another thing, in your mental status examination, please include why did you use this insight grade 1/6? Which reference is this? Because there are insight is only 1, 2, 3, 4, 5, 6. It is not a numerator denominator. So I think this is one common mistake that most people are doing. Okay, so it's grade 1 insight, so you just write a Roman 1. There is no need to write /6. Okay, so that's one. Also, you forgot to mention about RAPO. We, of course, when you were discussing, we figured out that she has been difficult, but you have to also mention about RAPO. And again, I'm going to reiterate the point that your family history should be only family history of mental illness, and your social history needs to be a bit more elaborative in female patients, not only here but in general. Do not forget to ask about menstrual cycle. And though in this case it may not be so relevant, but you also need to ask psychosexual history, which in her case may not be, I do not know. But it is important that you need to ask. Maybe at the first go, the patient might not be so comfortable to talk to you, but eventually that is something that also needs to be asked. Yeah, I think that's pretty much from my side.
Thank you. Thank you so much, sir and ma'am. So on behalf of PG Education Subcommittee, I would like to, yes,
Romesh, just before that, if Ruturaj, if you have any questions for the Parag sir and Hina ma'am, if you want any clarifications, or students, almost 80 students joined, sir, today.
Yes.
So if students have any queries, they can ask, because you won't get such opportunity.
Ma'am, I had one doubt mainly
Yeah,
regarding
sure.
the treatment part. Mostly when describing pharmacological management in the acute and short term, I usually, while presenting, only mention the first line treatment that I am about to do, and I am usually prepared for what will happen if this goes well. So, do I have to mention the alternative or the plan B?
No, 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 no. You see, you let them lead you. Okay. So you tell them, but in the event that they ask you, what if this does not work, this does not work, and all, so then you should be ready.
Yes, ma'am.
So that's good that you've decided that you want to give olanzapine. Oh, by the way, I did not get an answer to why clonazepam 0.25.
Ma'am, actually, uh, even if we are
Like
giving,
it's like is it really warranted? Like when do we usually use? Do we just use clonazepam only for sleep, or do we use it because there is agitation? I mean, if you're giving something, you have to justify why you're doing. So
so
that is
ma'am,
something that the examiner will ask you. See, you've chosen olanzapine. Somebody could have said that, Ari, you could have also started risperidone. So you don't directly dismiss them. You can say that yes, yes. But
yes, ma'am.
however, in my center or what I have treated, I have seen that patients respond even to olanzapine. But yes, sir, or yes, ma'am, even risperidone 2 milligram could also been given. So you don't refute them altogether, but then at the same time you also accept what their suggestion is. Having said that, I have no problem with your choice of antipsychotic. Olanzapine is a good molecule, no doubt. So yeah, why clonazepam?
Ma'am, actually, clonazepam was opted for its even anti-anxiety and muscle relaxant action and additional
So
sedative.
yes, so rather than just saying only for sleep, but I just feel that a little bit 0.25 is too low dose. A 0.5, maybe a BD or a TDS wouldn't be wrong if you say, it is just for acute agitation. So the idea is that whatever you say, there has to be a rationale and a justification behind this. So if there is somebody, say, an old timer, and if they said that, why not haloperidol? Why not trifluperazine? So what would you say?
Definitely, those drugs could also be good first line drugs for this patient. However, due to availability as well as lesser risk of EPS, I had personally opted for.
So you can I guess even atypicals would be available, no, in your in-house schedule. I mean, besides haloperidol and trifluperazine, that's okay. But I think one of the reasons that you can say is yes, that they are equally efficacious. And all, but considering the fact that the first line antipsychotics or the typicals are associated with more EPS, I preferred. And it's not to say that the second generation don't have their side effects. They too have their side effects, but it is equally mindful. Like I said, you do not refute them. You just go with the flow.
Okay.
Yeah. I think I can see a couple of questions coming in the chat box. Yeah. Romesh, if you would want to take them up. Hello.
Is attention, hello,
Hello.
Yes.
question from
First,
Vishal. If attention is not sustained in MSC, can the patient's memory can be tested?
Parag sir, if you could.
So I think you can definitely, you should be checking the memory, and if you may find immediate memory affected, and the reason and the explanation for the same, you can point towards the inattention as a problem. Another question before that is, should history of present illness start from the first episode in chronic patients with multiple episodes, or start with the present episode and mention previous episodes in past history? So, if I'm an examiner or I'm a consultant who wants to have a very good information about the ongoing discussion of a case, what would I expect to hear from you is clinically what is most relevant and important for me. So I would want you to start with the history of present episode in your chief complaints and ODP primarily to begin with, so that I know that okay, like this guy or this woman for last 3 months or 6 months has currently been passing through this current episode in this manner, the whole details, complete details. When you then go to the history of present illness, the next thing I would like to know and understand is when all the whole illness started, like how before 7 years, okay, 4 episodes, okay. And second most clinical information important for me is how all the illness started. What was the first episode look like? So then I would be interested in you giving some more emphasis on the onset of the illness, that is the first episode, some more details about it in history of present illness, and after that you throwing some light onto the number of episodes, how all the episodes in between the first and the current were in general gross, and how was the inter-episodic period like for me to understand the course and the pattern of illness. I think this much of information is enough for me to have a good impression about what all the diagnosis is. Of course, there is a scope for going into more and more details about this aspect of the history, but this is most relevant according to me. Yeah.
I
Another
think
question
somebody
is
has
should,
also
yeah,
asked
yeah,
regarding
yeah,
where
please.
orientation should be mentioned. So I think the usual practice that what we follow is we always mention orientation after perception and before memory. But I did notice, Ruturaj, that you had mentioned orientation way higher up, just even before your attitude, appearance, and behavior. But I think if you look at most institutes, it is usually orientation usually comes lower down, because when you have already done your CNS examination in your higher functions, you have already tested that aspect. I am assuming that you have done CNS examination. It is expected that you do CNS examination. So I feel, and if you also look at standard textbooks, I think there is a sort of a contradiction here, but I think you just see what is the examiner saying, gauge his mood, and then decide.
I would tell Ruturaj, no one will fail you for keeping orientations at the bottom or in the
Or
middle or
below.
at the
True.
top. Idea is you should know that orientation is required. In BMC colleges where we have done our post graduation, orientation was quite in the beginning, but in the textbooks it was a part of cognition. So now
Yeah.
cognition comes below thought and
Below
perception.
perception,
So the
yes.
first part of cognition starts with the orientation. Uh, if there is some controversy, you can very well say, sir, in our institute, we are following this mental status examination protocol. And that's fine enough. Idea is you should assess that the placement may vary somewhere here and there.
So I think that is okay. Somebody else also, I believe, has something. Some questions are coming more on
Yes.
history, is what I have realized. Should
Uh,
negative history present after current history or after previous history? Okay, so negative history present after current history. So you were basically describing the history of presenting illness. You're going to be talking about that current episode. Okay, so in that current episode, if there is anything significant, you need to ask those questions. Well, in your case, maybe the only significant thing probably would have been organicity, any history of substance in the current episode. So maybe the order has to come in that order. Orientation is what all should be mentioned in social history. So in social history, definitely who the patient is staying with, there has to be information about the family. So that would include the parents. What are the parents doing? How old they are? What is the job? Who is the bread earner? If the patient is a sole child or if there are siblings, then information needs to be presented about those siblings. How old are they? Whether they are married? What are they doing? What are their interpersonal relationships like? Okay, so I think most of the times people feel that social history is very relevant in a child case, but no, that's not true. Social history is relevant in each and every history of psychiatry. So that is very, very important. if like what Ruturaj mentioned in the beginning, all those details that came about the divorce could have actually be presented here, that they have been married for so long, but within so many months or within the first year of marriage itself, there was a problem. And then ultimately 1 year ago, the patient has, are they officially divorced or are they separated? What is it, Ruturaj?
Ma'am, initially when he had left her at mother's house, they were not divorced, but since
Okay.
then the legal
So all
procedure.
those details also, so you need to ask them that are they officially divorced? So has a decree been obtained, regarding the same? And and in our case, especially, it's only the mother who is the primary caretaker, and she too is widowed because they have lost their father. So everything about the interpersonal dynamics, the finances, and all those things need to come. This is what comprises social history. Yeah. Should verbatim of patient include in history? Some sentences, yes, but you just cannot, you cannot be taking history in their colloquial, or in their local language. Certain terms, yes, like when they say ke ghabrahat hoti hai, chidchid hota hai, which you mentioned, but no, it cannot be literal verbatim. But at the same time, you also have to avoid using too many medical words. So the words like delusions, hallucinations, and all will feature only in your mental state examination and not in your history otherwise. Yeah. Would it be ideal to follow the IPS guidelines and format of history and MSc? I don't know whether it is ideal or not. What is ideal is what you've been taught. But what is a good practice is that, yes, you must be aware of what is your own country's guidelines. Like I said, it's very good if you know Maudsley. It's very good if you know the NICE guidelines. And but what is equally important is you should be aware of what are IPS guidelines. So I would suggest that it's a good practice to also go through them. Yeah, I think all questions are done.
So thank you so much, sir and ma'am. So on behalf of PG Education Committee, I would like to extend my gratitude to our faculty member for their insightful and valuable opinions. They are really the OGs or academics that Sushil Gawande sir has brought today. Now, I would like to take this moment to thank Dr. Sudhir Bhave sir, Dr. Gawande sir, Dr. Abhijit Pai sir, and our entire team of PG Education Subcommittee, Dr. Silpa ma'am, Dr. Sri Lakshmi ma'am, Dr. Balchandra sir, Dr. Prajakta, Dr. Drone, Dr. Vinona, and Dr. Saili for their tireless efforts in organizing the entire session throughout the year regularly. I would like to, also like to thank the technical team, that is Yogendra ji, for his support. I would like to thank each and every single attendee, faculty, and PG student for their active presence. Now, at last, I would like to thank the Psychiatric Society of West Zone to provide such an unique and really scholarly session throughout the year. Thank you so much.
सुशील,
Sir, you
जाते
are
जाते
muted.
एक गाना नहीं गा के जाओगे हमारे लिए?
Yeah, we can always but I don't think it's the end of series. Next year even we would do better. We would try to do better, or even a next chairperson would do this. Yes, I would hum. चलते चलते मेरे ये गीत याद रखना, कभी अलविदा ना कहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना. Thanks, Hina. Thanks for
Thank you
joining.
so
Thanks,
much.
Shilpa ma'am.
Thank you,
Thank
thank you,
you,
Sushil.
everyone.
Thank you, Bhave sir. Thank you,
Thank
Shilpa ma'am.
you.
Yes,
Thank
and
you.
best
Dr.
luck
Ruturaj.
to all students. They are going to appear for their exams.
Yes, all the best to
Yeah.
everyone.
All
I'm
the
sure
best,
this
Ruturaj.
session would help.
Yes, definitely. Thank you, ma'am.
Thank you.
Bye-bye.
Thank you.
all.
Bye.
Thank you.
Thank
Thank
you.
you. Bye.